And with that, I think we're ready to kick off the program. And so I'm going to begin with our first talk by introducing Dr. Elaine Wirrell from Mayo Clinic. Dr. Wirrell, I also want to give a special thanks to her for helping us plan the program, in addition to Doug Smith from Minnesota Epilepsy Group, who will also be presenting later today. They've been a great support to us in planning this meeting, and we really appreciate it. So Dr. Wirrell is going to kick the program off by giving us a brief overview of Dravet syndrome, followed by really delving into the best treatments to date for Dravet syndrome.
Well, thank you very much, Veronica. It is really exciting to be here, and it's so exciting to be partnering with the Dravet Syndrome Foundation to offer this meeting in the Midwest, in Minnesota, my home state. So thank you so much for the opportunity to do that. We're excited to see so many people here today. So as Veronica noted, I'm going to be giving just a brief overview. I know that Dr. Laux had talked about this a little bit last night, but I'm just going to do a very quick overview of what Dravet syndrome is. And then we'll look at the current treatment options. Dr. Perry is going to be enlightening you on some of the really new exciting therapies that are coming down the pike, but for now we're going to be focusing more on the current treatment options. So the objectives for today are, first of all, what is the typical clinical presentation of Dravet syndrome? And other than seizures, what other symptoms are there? And then what are the currently available therapeutic options? Really asking how well do they work, how well do they control seizures, and importantly, how well are they tolerated? So when we look at Dravet syndrome, this is from a study from Australia where they looked at a large number of patients with Dravet syndrome. And we know that kids with Dravet syndrome usually present in the first year of life, occasionally up to 20 months, but usually in the first year. And the initial presentation is with a seizure. And in this study, the average age at seizure onset was about 6 months. The initial seizure in most cases is tonic-clonic in about half of cases, or hemiclonic, just one side of the body, in about a third. Rarely other seizure types can be the presenting type, but that's pretty uncommon. And as you all know, prolonged seizures are very problematic in people with Dravet syndrome. And in fact, with the first seizure, a third of patients presented with status epilepticus, or a convulsive seizure going longer than 30 minutes. And the average duration of the first seizure was 15 minutes. So even if your first seizure wasn't a prolonged or a status seizure, it was still, in most cases, prolonged. And then once the seizure happens, we know that, typically within weeks there's going to be another seizure. And in this study, the average time between the first and the second seizure was just 30 days. As you all know, triggers are really important for patients with Dravet syndrome, particularly in childhood. Anything that elevates the body temperature, so fever, hyperthermia if you're in Minnesota in July and it's 90 degrees outside, if they're very active, intense activity. Sometimes with vaccinations, you can have a little bit of an elevated body temperature, and in some cases that can be a trigger. And then fatigue, the child is overtired, and many families really have developed pretty good insight. My child needs a nap. If I don't get them a nap now, they are likely to have a seizure. And then also excitement. And I have quite a number of families that say, birthday parties are not good places for my kid, or family reunions or family weddings, because there's just too much excitement and that's going to trigger something. We also know that there are certain medicines that we should not be using, and particularly the sodium channel blockers, things like carbamazepine or Tegretol, oxcarbazepine or trileptal, phenytoin, and even lamotrigine or Lamictal. So those are things we want to avoid. So by the preschool years, oftentimes we still see those prolonged seizures, which are the most problematic seizure type at the time of presentation. So those are often still persisting, but we see other seizure types evolving. And these can include focal impaired awareness seizures, where the child simply stops and stares and may have some picking. Myoclonic seizures, which are just brief, abrupt jerks. Absence seizures, which are staring spells. And then less commonly, drop seizures. By adulthood, most of the patients have brief convulsive seizures, often at night, and oftentimes the risk of those prolonged seizures is much decreased. It's not gone completely, but much decreased. And oftentimes we see those other seizure types that have come on during the preschool years going away. And you're going to hear a little bit more about this from Dr. Burkholder. Now, we know that Dravet syndrome is not all about seizures, right? So development is a big concern. And again, at initial presentation, the children are developmentally normal. So we do not see any evidence of delay at the time they present with their first seizure, but over time, that becomes more concerning. And again, this is from the large study of Dravet in Australia by Ingrid Sheffer's group. They found that 99% of kids with Dravet actually were ambulatory, so they were able to walk on their own. But oftentimes for longer distances, that's more challenging, so many of them need wheelchairs or strollers for longer distances. About 97% have at least some verbal communication skills. Autism spectrum was found in 38%, but that we know is probably an underestimate. If you talk to parents, parents say there's a lot more concerns about autism spectrum features than we as physicians are recognizing, and I think that's important. And then this is looking at the intellectual function at the last follow-up, and we see here that almost all patients have some degree of intellectual disability, but that degree is quite broad. So we see some with severe intellectual disability, some really with just borderline or mild intellectual disability. And I think now with our better treatments, the likelihood that the kids down the road are going to be doing better developmentally, I'm feeling very positive about that. And then this is looking at when did the families, or when was there evidence of developmental slowing? And you can see here that most of the children, if you're watching them carefully, you see kind of concerns arising around 18 to 24 months of age. Most of the kids are not losing skills, they're just slower to gain those skills. And then here's some data from France. Now, this is recognizing an older patient group, and many of these patients did not have access to early diagnosis and did not have access to the better therapies that we now have. So we know here that a lot of these patients will have issues with intellectual disability that is often severe, and about half of these patients will be completely dependent or near completely dependent as adults. But again, recognize now that we are making the diagnosis earlier. We have the availability of genetic testing, which allows us to say, this is Dravet, and so we don't want to use these medications. And also, this is Dravet, and here's some better medications that we can use. So I think down the road, things are going to be more favorable. So other non-seizure symptoms or comorbidities. So we know that behavior is quite common. This is work from Kelly Knupp, who many of you know from Colorado, and she found that inattention and hyperactivity symptoms were present in about 69%, and then many patients will have sort of more of an obsessive perseveration on things, and that's seen in about half. Sleep is a big, big concern. I kind of feel like I'm preaching to the choir here, but sleep is a huge concern for families. Very high rates of parental reported sleep problems, and they're across the board. So this, again, from a study from Australia, about 39% of families reported the child had difficulty initiating and maintaining sleep, so just getting them and keeping them asleep. About 35% sort of problems with transitioning from sleep to wakefulness. About a third of them had problems with sleep breathing, where they would snore or have obstructive sleep apnea. And then we know gait problems. So walking is slightly delayed, but again, most kids with Dravet do walk. Many of them are what we call ataxic, so their balance is not as good. And typically by late childhood or the teen years, we have this very typical crouch gait where they kind of have, flexion at the hips and then flexion at the knees. Growth and appetite is also a concern, and many families describe issues with appetite and eating. That is often not helped by many of our medications, which also have a negative impact on appetite. But kids with Dravet appear to have their own growth curve as well, and that's a little bit different than neurotypical children. And then the issue of premature death and sudden unexpected death in epilepsy. This is something that, as a clinician, I worry about this all the time, and I think as families, this is even more challenging, just to live with this, and because it is obviously very devastating. There's been a couple of studies that have looked at this. The Cooper study followed 100 patients with Dravet syndrome to an average age of 17 years, and found the mortality rate was about 16 per 1,000 person years, which is over 1 per 100. And when they looked at what were the reasons that people died, almost 60% were due to sudden unexpected death in epilepsy. And this is a condition where, the patient will usually be sleeping. The assumption is they've had a seizure in their sleep, and they're found having passed in the morning, so very concerning. About a quarter of patients died due to status epilepticus, smaller numbers due to drowning or asphyxia. Asphyxia is choking. And the more recent study from Australia again documented over half of deaths were associated with SUDEP, so again, a really important concern. We're going to be hearing from Tom Stanton, who's going to be talking to us about the different monitors that we might look at to try and pick that up. And then cerebral edema. Cerebral edema is recognized now as a cause of death that is related to usually young children who have very prolonged bouts of status epilepticus with very high fever, and some of those children then are found to really not recover, and they have significant changes on their MRI. Some of those children pass away as a result of those significant injury to the brain. Other ones are left with new permanent deficits. So we know that that's a concern as well. So talking about making the diagnosis, and again, Ingo Helbig is going to talk a little bit more about genetics, but we know that the vast majority of patients with Dravet syndrome have pathogenic variants detected in SCN1A. Most often these are what we call de novo mutations, so these are not mutations that are carried in the family and are not variants that are likely to be passed down to other children, but there are rare changes where the change can actually happen in the mom's egg or the dad's sperm, and those are really important to recognize because that does increase the risk of recurrence. So that's really why we recommend a lot of, or all of our patients with Dravet syndrome to see a geneticist to really look at that. We also know that just having an SCN1A variant does not equate to having Dravet syndrome. So it is important to look at the type of variant, and it's also really important to correlate that with the clinical picture. We know that there are gain-of-function SCN1A variants that present with a very severe early onset epilepsy syndrome that are different than Dravet syndrome. And we also know that there are other children who have a much milder version called genetic epilepsy with febrile seizures plus. And so it's really important to not only say this is an SCN1A variant, this is Dravet, but this is an SCN1A variant, what's the clinical picture? And it might be Dravet or it might be something else. And very, very rarely there have been other reported genes associated with Dravet syndrome. If you look at the reports of those, most of those kids have somewhat atypical features for Dravet syndrome. So the EEG, neurologists love their EEG, but the EEG in Dravet syndrome is not very specific in making the diagnosis. Oftentimes after a seizure, you might see some slowing. The discharges can be many different types. You can either have none, or you could have focal, or you could have multifocal, or you could have generalized. So it's not so helpful. One of the clues is that some of the children with Dravet syndrome with the photic stimulation, the flashing lights, can actually have discharges elicited by those flashing lights, what we call a photoparoxysmal response, and that can be sometimes a clue that we can see early on. Looking at the MRI, that is usually normal at seizure onset. With time, as the kids get older into adulthood, oftentimes you see a little bit of atrophy. Sometimes you can see some scarring in an area of the brain called the hippocampus or the temporal lobe, and that we think is secondary to seizures as opposed to the primary cause of the seizures. So sometimes, if we see hippocampal sclerosis, people might say, oh, maybe epilepsy surgery can be helpful if we remove that area. Usually that's not the case, usually not helpful. So let's talk a little bit then about the goals of treatment in Dravet syndrome. And I think it's really important to have a discussion with your provider. For each family, this is going to be a little bit different. And so have that discussion and find out what are the important goals for you and your family. The seizure goals usually are more age dependent. So less than 2 years of age, these are the kids having often prolonged seizures or recurrent status epilepticus. And so we really need to focus on how do you prevent those prolonged seizures. So it's reducing the seizures, but also reducing the fact that they could go on for 15 minutes or 30 minutes. Between 2 and 10 years, it's really still focusing on trying to reduce those prolonged seizures, but also these children can have different types of seizures, right? Absences or myoclonus or focal impaired awareness seizures. And if those are happening very frequently, that can also tremendously impact their ability to communicate, quality of life, things like that. So those also need to be addressed. And then in older teens and adults, the main seizure type they have are those nocturnal convulsive seizures. And those are the seizures that still place them at significant risk of sudden unexpected death in epilepsy. And so it's really addressing those as well in the older teens and the adults. We generally say that elimination of all seizures is not, in most cases, feasible. And I think that's important because, you know, if you have a chance of improving seizure control, then it makes sense maybe to add another medication. But to be on, you know, 6 medicines and to add a 7th when the likelihood of getting you seizure-free is very low, I think we have to then balance what is the potential impact on quality of life of all of those medications and side effects versus what is the potential benefit or what is the potential impact on quality of life from the seizures. And so that's really a balance. We want to minimize side effects, obviously. Avoiding excessive polypharmacy is part of that. But having said that, most persons with Dravet syndrome are on at least 2 or 3 medications. And then I think really important is it's not all about the seizures, right? We want to manage those comorbidities to really maximize quality of life, both for the person with Dravet syndrome as well as their families. So a couple of years ago, we, together partnering with the Dravet Syndrome Foundation, did an international consensus. And so we identified expert clinicians and caregivers who had a lot of knowledge, not only about their own loved one with Dravet, but a number of other patients with Dravet syndrome as well. And we came out with this consensus. So how should we be using all of the medicines that we have? And we had actually very broad representation internationally from all continents. So the first-line medication, there was a strong consensus that should be valproic acid. Second line could include fenfluramine, and fenfluramine had just recently come out at that time, or potentially stiripentol together with clobazam, because we need to use those two together. Or you could just look at clobazam alone. So there was a little bit more leeway for second-line medications. For third-line medication, pharmaceutical-grade cannabidiol, and then other, further down, topiramate ketogenic diet, fourth line. But was also really important, things that we should not be using. And those are what we had talked about, those sodium channel agents, which typically worsen seizures. So why is controlling convulsive seizures actually important in Dravet? Well, it's important because we'd like to reduce the frequency of seizures, right? That's going to make our lives better because we're not having to race into the ER. We're not having to worry about things like SUDEP as much. But also there is some evidence that if we improve convulsive seizure control, that actually may also improve some of our other non-seizure outcomes. So this was a study that was done from the fenfluramine study, and what they found is they looked at patients who had a higher degree of seizure control, and so those who had a greater than 50% reduction in convulsive seizure frequency in green, or even a greater than 75% shown in orange, and then compared those who had less than that, which are the gray group. And what they found is that those who had better seizure control had less significant emotional issues and had greater improvements or greater cognitive benefits than those who had lesser degrees of seizure control. So by improving seizure control, this does suggest that that can also improve some of our non-seizure outcomes. So let's talk a little bit about what is the evidence. So we have a bunch of older medicines, valproic acid, clobazam, topiramate, levetiracetam. Maybe these are not so old, but they are considered older. And they lack what we call class 1 evidence. So in the new trials, what they've done is you have a group of patients, part of them or half of them get the active medication, half of them get placebo. The family doesn't know what the patient is on, the clinician doesn't know what the patient is on, and then the family rates, has there been improvement in seizure control? They log their seizures. And so that's what we call class 1 evidence, so it really removes all bias, and that's sort of the highest quality evidence we have. For these older medicines, we don't have those type of trials, and we are unlikely to get those type of trials, because if somebody came to me and say, hey, I'm doing a class 1 trial of valproic acid and Dravet syndrome, I'm not going to sign up for that, and I don't think my families will either, because we think valproic acid works, right? So you're not going to sign up to put your child on a placebo medicine if you really think it works. So this is what we are left with. For valproic acid, responder rates are people who have greater than 50% reduction in their convulsive seizures, somewhere between a quarter and half of patients. So yeah, it works. Not great, but it works. Clobazam, responder rates about 28%. So again, works, not great. Topiramate, a little bit more of a range, a third up to 78%, and those were very small studies, so that's one of the challenges. And actually levetiracetam, or Keppra, which is one of the first medicines most kids with seizures in the US get put on, actually is not very effective. So let's talk about some of our newer medicines that have been approved. So fenfluramine, or Fintepla, was recently approved by the FDA. It is approved for persons with Dravet syndrome 2 years and older. And it is available as a liquid medicine. You can only get it as a liquid, and you have to give it twice a day. The dose is up to 0.7 milligrams per kilogram per day, and also you kind of have a maximum dose. So typically by the time you're hitting 35 or 40 kilograms, you hit your maximum dose, so you can't go higher. If you're using it together with stiripentol, that maximum dose is lower, and that's because there's a drug-drug interaction between those two. And this is kind of a new mechanism of action. There's two possible, I think, factors in play here. So first of all, something called the sigma-1 receptor. I don't know very much about the sigma-1 receptor, but the company tells me that that's maybe a positive modulator. And as well, the serotonergic effect. So this is a serotonergic agent. And so that potentially can have side effects if you're combining it with some of the other medicines we use for sleep and behavior. So that just needs to be considered. And so how well does fenfluramine work? So the first study, I'll see if this works here. All right, so the first study over here was the study where they looked at fenfluramine in kids who were not on stiripentol. And what they did is they had a group that were on higher dose fenfluramine in green, on lower dose fenfluramine in blue, and on placebo in red. And what they did is they looked at what proportion of patients had a greater than 50% reduction in seizures. And as we can see here, that number was 68% on the higher dose, and it was only 12% on placebo. And when they took sort of a step up and they said, how many have a 75% or greater reduction? Again, we're seeing that number is about half of patients in the higher dose and only 2% on placebo. So that's clear evidence that fenfluramine was helpful in many people with Dravet syndrome. They did a second study combining fenfluramine with stiripentol, and as I mentioned, there's a drug-drug interaction, so you need a lower dose. But again, you can see here the treatment group up here in blue versus the placebo group in yellow, and again, we see greater degrees of seizure control in the treatment group. So this provided very high-quality evidence that fenfluramine is helpful for many, not all, but many people. And then this was what they call an open label extension. So after they do this trial where half of the people get real medicine, half of the people get sort of a placebo, at the end of that, everybody gets to go on to the real medicine. And so they followed patients, 232 patients, an average of 256 days. And what they saw was that benefit that they saw initially was maintained over the long term. So it didn't seem that we got a significant honeymoon effect where things worked well to begin with and then they lost their effect. No, this benefit was sustained over the long term. And then looking at how well was it tolerated, and this medicine actually was initially used as a weight loss drug. I think many of you are aware of that. Back in the 80s and 90s, people took it to try and lose weight. And so not surprisingly, the side effects that we saw with that were some decreased appetite, some loose stools, a little bit of fatigue and lethargy. But most of the patients, this was manageable with lowering the dose, and oftentimes these side effects abated with time. There also potentially is a concern with this medicine and heart disease. So when this was being used at much higher doses for obesity, some of the patients had thickening of the heart valves or a heart disorder called pulmonary hypertension. And so in the clinical trials, this was monitored really closely. And in the clinical trials, they did not see any patient who developed those side effects. So not to say those side effects can't happen, but they're pretty rare. So in summary, for fenfluramine, half to 2/3 of patients achieve a greater than 50% reduction in convulsive seizures that's maintained over the long term. The side effects related predominantly to decreased appetite, some weight loss, and some fatigue. No evidence, at least in the clinical trials, of heart problems. And so this has now been approved for the treatment of seizures associated with Dravet syndrome in people 2 years and older. So next we'll move on to cannabidiol, or Epidiolex. This is the pharmaceutical grade product, and this also comes as a liquid. It's a strawberry flavored oil. There isn't an IV preparation, there are no tablets, and the dose is anywhere from 10 to 20 milligrams per kilogram per day. This, we don't exactly know how it works, but there's a lot of different possibilities, and probably there are several ways in how it works. It is important if we're using Epidiolex, it does have that drug-drug interaction with clobazam, and so if you don't reduce the clobazam and you're on high dose, then your clobazam levels can go very high and you might become very, very sleepy when this is added. That's not because the cannabidiol is making you sleepy, it's the cannabidiol that's pushing those levels of clobazam up that is making you sleepy. So this is data from the clinical trials. And there was a couple of clinical trials done. The first study really looked at 20 milligrams per kilogram versus placebo in gray. And the second trial looked at 2 doses, the 10 and the 20 compared to placebo. And what we can see here was that there was a significantly greater reduction in people who got the actual drug than people who got placebo. Interestingly, there was not a huge difference, right, between people who got the lower dose, the 10, or the higher dose, the 20. But overall, about a 40% reduction in convulsive seizures. And again, in the open label extension, that benefit was maintained. So we saw that benefit persisting over time. Looking at the tolerability for Epidiolex, we saw some decreased appetite, some diarrhea or loose stools, and some sleepiness. Many patients, again, that was manageable with reducing the dose or going up more slowly or just tincture of time. Many times this just fades out and is no longer a problem after several weeks. There is a potential that this can lead to elevated liver enzymes, and that's particularly in patients who were also on valproic acid, and so that needs to be watched. None of these patients, importantly, went into liver failure. So a summary of how well this Epidiolex or pharma-grade CBD works, about a 40% reduction in convulsive seizures from baseline that seems to be maintained over the long term. The side effects, again, relate to some sleepiness, a little bit of tummy upset, loose stools, nausea, vomiting, and very rarely elevation in liver enzymes that needs to be watched. And then we do need to be aware that it can drive up the clobazam levels. So if you're already on clobazam and this is being added, you want to make sure that that clobazam doesn't go too high. And so this is now approved for seizures associated with Dravet syndrome in the US in persons 12 months and older. So it's got a slightly younger approval. Moving on to stiripentol. Stiripentol comes as tablets or sachets, and you can dissolve the powder in the sachet and give that more as a liquid. It also has multiple mechanisms of action that likely explains how it works. It is dosed, and the dose really depends on the patient's age. The younger children need higher doses, closer to 50 milligrams per kilogram per day. If you try and treat an older child or a teenager or an adult with that dose, they will go to sleep. So you really need to make sure you reduce the dose appropriately as that patient gets bigger. Also, this has a very similar interaction with clobazam in that it drives the levels of clobazam up. So if you're on high doses of clobazam and then you start stiripentol, you need to reduce the dose of clobazam, otherwise your patient will go to sleep. And really, there's no evidence to support that this is effective on its own. It always needs to be used with clobazam in the US, and outside of the US, most of the other jurisdictions ask that it be used together with clobazam and valproic acid. So this is an older study now. This is from 2000, done in France. And this is where they had stiripentol added on to patients who were already on clobazam and valproic acid who had Dravet syndrome. And we see here, again, if we look at reduction in seizures, much, much higher in the blue group, which is the stiripentol-treated group, versus the placebo group shown here in red. And they also documented that in their, and then remember this is over a short course of the study, but slightly over 40% of patients actually were free of convulsive seizures. I must say in the long term, I think I have very few patients who are completely free of convulsive seizures with any medication, including stiripentol. So looking at long-term use, this was looked at in Japan, and they had 305 out of the 410 patients continuing to use stiripentol, so it was clearly worked well enough and was tolerated well enough that they continued it. And they saw the effectiveness for the different seizure types. For convulsive seizures, it reduced them by 50% and 43%. For focal impaired awareness, that number was 55%, and for myoclonic and absence, that number was 62%. Stiripentol does have some side effects, so again, it can also lead to some sleepiness. That sometimes can be related to clobazam not being reduced appropriately. It can cause some decrease in appetite, but otherwise they didn't see anything new safety-wise. And then this is looking at the safety and tolerability. So again, we see drowsiness, some decreased appetite, decreased weight, and sometimes if you do blood work, you can see that the white blood cell count comes down transiently and then it comes back up. So that does not seem to be a big concern, the white blood cell count. There's been now some newer data that has come out. I think one of our challenges is we are now making the diagnosis of Dravet syndrome often in the first year of life because we have the genetic testing, because there's more awareness thanks to the Dravet Syndrome Foundation about, what is Dravet syndrome, so physicians are thinking about this. And so we're now often making this diagnosis less than a year, but recognize that a lot of our newer medicines are not approved until 12 months or even 2 years of age. And so this was data from a large French database that looked at 131 infants, and they found that stiripentol's use in infancy significantly reduced the risk of prolonged seizures or status epilepticus. So that's probably its clearest benefit, is reduction in those prolonged seizures. The number of side effects actually halved once they used to recognize the right dose. They used to use a much higher dose, and then when they went down to sort of a maximum of 50 milligrams per kilogram, the kids tolerated that much better. Again, loss of appetite and sleepiness was the biggest side effect. No new side effects reported in this age group. And so to summarize stiripentol, so it does show a significant reduction in convulsive seizures when used as an add-on to valproate and clobazam, and now the FDA, if we're going to use it in this country, we have to use it together with clobazam. Side effects, predominantly drowsiness, some appetite issues and behavior change, and this has now been approved for use down to 6 months of age. And so this is, I think, a big step forward. We're making the diagnosis early, and we now actually have a medicine we can use earlier. So as we talked about, contraindicated medicines, these are things we don't want to use. So those sodium channel blockers, these need to be avoided, at least for what we call prophylactic use. Prophylactic means a medicine you take every single day. There is still some argument that things like phenytoin can be used for status epilepticus. And then lamotrigine is one of those sodium channel blockers. That probably should not be used in children. There are some rare reports of adults who are now being diagnosed with Dravet syndrome who are on lamotrigine, who get into a little bit of trouble when that is reduced. But I think overall we want to be very cautious about lamotrigine. It would not be my first, second, third, or fourth, or probably fifth choice. A few words about non-pharma grade CBD. From our consensus, the physicians felt this should not be recommended. Caregivers, there was really no consensus on this. The concern is that this product contains more potential tetrahydrocannabidiol, or THC, and that is the portion of the medical marijuana or marijuana that actually makes you stoned, that has cognitive impact. And so from our study, we had 16% of physicians, 37% of caregivers who reported that they had experience in patients who were using low-dose THC in Dravet syndrome, and all of them said that they had not seen any substantial benefits. So I think this is certainly something we want to be cautious about. Dietary therapy, so ketogenic diet is often considered early on in some of our drug-resistant epilepsies. And from our consensus, we felt this was not really a first-line therapy, but certainly should be considered after failure of 3 to 4 medications, and that was strong consensus both from physicians and caregivers. Which diet is best at specific ages? For the very young children, the classic diet where you have to calculate and weigh out everything is still felt to be probably the most efficacious or effective treatment for very, very young children. For school-age children, we didn't really get a consensus as to which one was best. And for adolescents and adults, sort of a looser ketogenic diet, either a modified Atkins or something like a low glycemic index, where there's sort of a guidance for what you eat, but you don't have to weigh and measure everything. And it just gives you more flexibility as well if you're going out to dinner or things like that. A few comments on the vagus nerve stimulation. Again, our consensus felt that this would be appropriate, but should be considered maybe after 3 medication trials have failed to control seizures. And consensus that valproic acid, clobazam, stiripentol, and ketogenic diet should be used if those were feasible for the family, and potentially fenfluramine, cannabidiol, and topiramate, recognizing that people in our international consensus didn't all have access to fenfluramine, cannabidiol. The usual benefit, caregivers and physicians agreed that the usual effectiveness of this is less than 50%, so the likelihood of getting a greater than 50% reduction in seizures with vagus nerve stimulation was quite low. However, the magnet itself, when you have one of these, you can actually, as soon as you start having a seizure, you can swipe the magnet and you can actually turn on the stimulator, and that can stop the seizure. And so for many people with Dravet with long seizures, that can be pretty helpful. The caregivers, interestingly, rated the effectiveness of the magnet at stopping the seizures higher than the physicians. They're the ones using it, so I suspect they're probably right. Dr. Starnes is actually going to be providing further updates on neuromodulation, so he'll discuss this in a bit more detail this afternoon. The role of other neurosurgical therapies, some people have thought about corpus callosotomy, which is disconnecting the 2 halves of the brain. There's really no role for that in Dravet syndrome. And then temporal lobectomy, where if there's a little bit of scarring in one area, again, the likelihood of that resulting in significant benefit is very low. So resective surgeries or bigger epilepsy surgeries are probably not a good idea. Rescue therapies, so we know that all of our patients have the risk of going on to have a long seizure, and so all of our patients do need a seizure action plan, and they need a home seizure rescue medication. And I'm going to leave further discussion to Dr. Smith, who is going to enlighten you on that next. And then don't forget the comorbidities. So we know that Dravet syndrome is about much, much more than just seizures, and those comorbidities have a significant impact on quality of life for the child and the whole family. Intellectual disability usually starts to appear around 2 years of age, and then as you go forward, the gap between neurotypical children and kids with Dravet tends to widen with age, just because the kids with Dravet are gaining skills at a slower rate. Other associated symptoms can affect quality of life, and I think caring for a child with Dravet syndrome really does involve multidisciplinary care, so we need access to sleep specialists, to mental health providers, to gastroenterologists, respirologists, things like that. We know the caregiver burden is very high. We know that many families, both parents are not able to continue to work full-time, and that can also have a significant economic impact on families. We are very excited about these new treatments that are coming up. They're compelling, but we also need to be sure that they account and they measure more than just seizures. So multidisciplinary care we had talked about. Kids with Dravet syndrome, people with Dravet syndrome Gait problems, Parkinsonism, Danielle Andrade is going to talk about that, cognition and behavior, seizures, obviously, appetite and feeding, some endocrine issues, sleep issues, and Dr. Matarisi will discuss that. And so really having sort of access to experts that can really help address all of these aspects. I think there is a lot of hope for the future. We now have some anti-seizure medications that are really targeting novel targets that we've not targeted before. There's a current trial ongoing using antisense oligonucleotides, which is really changing the protein amount, the SCN1A NaV1.1 protein. There's genetic studies that have just been started, and so they've actually just dosed their first patient with a gene therapy, which is really exciting. And Scott Perry is going to talk to us about that, but I do think there really is hope ahead. So to conclude, Dravet syndrome is a drug-resistant, lifelong, early-onset epilepsy. We want to think about this in any child who presents in the first year of life, particularly with a febrile seizure that is either prolonged and or what we call hemiconvulsive, or just involves shaking on one side of the body. We know that seizures evolve with time. So in the preschool years, we start to see evolution of other seizure types, including myoclonus, absence, focal seizures. And then in adulthood, many of them are having most of their seizures at night. They're often convulsive and putting them at risk still for sudden unexpected death. We know that development is normal at onset. Over time, all patients, I think, develop variable degrees of intellectual disability, and I'm really excited about some of these new therapies, the earlier diagnosis, and I think we will be able to lessen the severity of that in the long term. And then other comorbidities, gait, behavior, sleep, growth, really need to be paid attention to. So we have now several recently approved Dravet-specific medications, stiripentol, fenfluramine, Epidiolex. Those have improved seizure outcomes for many families. We have dietary and neuromodulation options, and we're going to be hearing about some of the exciting new potential neuromodulation options from Dr. Starnes. And also several other promising therapies in the pipeline that really target the underlying genetic condition. And I think if we target that and we target that early, that will also likely improve the comorbidities that we see. So thank you very much, and I'm happy to take any questions.
Thank you so much for being here with us this morning. I have two questions. One, in your experience with dealing with sleep, is the difficulty with sleep, does that happen earlier or does that evolve as the kids age? And
sorry, there's just a little bit of an echo. You said sleep, is it earlier?
Like, there are problems with sleep. Do you see that typically as they're young and then that continues, or does that change as they age? And then the second question is, with MRIs, a lot of kids get it on initial onset of like seizures. How often do you recommend getting MRIs as they grow up?
Sure. So the sleep question I think is a good one. I think a lot of families with young children with Dravet syndrome co-sleep. And so that may be potentially less of a problem for them because the children are younger and they're co-sleeping. I think once your child becomes a teenager, that is, and still many families co-sleep, right? And so the child may not be in their bed, but is in their room on a mattress. I think that with time, there was one study that looked at sort of developmental and epileptic encephalopathies, of which Dravet is one group, and found that that was a little bit more common in sort of school-age children and adolescents, but I think it certainly can be a longer standing problem as well. And I think part of it's a little difficult to measure because obviously if you're a parent and your child has recurrent prolonged seizures, it's really tough to let them sleep in their own bed in their own room, right? For MRI, I think to make the initial diagnosis, you don't actually need an MRI for Dravet syndrome, but when a child presents with a prolonged seizure, that's something that we do to rule out other things. I think once you have a gene test and once you have confirmed the diagnosis of Dravet syndrome, there is not a reason to do just follow-up MRIs. I think sometimes you may have a clear question if your loved one with Dravet syndrome falls down and has a bad concussion, and you want to know if there's any bleeding or something related to the fall. But you're doing the MRI for different reasons, but I don't think you need to do follow-up routine MRIs.
Hi. My question is about the medication. So with multiple 5-HT receptor agnostic medication coming up, like Fintepla, lorcaserin, and bexicaserin coming up. So are we expect the different responses to each one of them? If you fail one of them, you probably will fail all of them?
Yeah, so that's a good question. I think that's one that we are thinking about as well. I do worry that if you have already been on a medication that targets a specific type of receptor, you would certainly have a lower chance if you have not responded to that one adequately, that if you tried another one, that you would respond better. But sometimes we're wrong, like for other epilepsies, non-Dravet, where we might have a sodium channel blocker that we've tried. Some kids will respond to one sodium channel blocker and not have responded to another. So I don't think we can say that definitively, but I think certainly the likelihood would be lower that they would respond. I think the different 5-HT ones that are out there now, some of them are going to be more tolerated potentially from a side effect issue, and then the question will be, can you go to a somewhat higher dose? Maybe you can't with a 5-HT that is going to significantly impact the heart valves, but maybe you can if you have something that is not going to impact the heart valves. We don't know that, but I think that's a good question.
Hello? Oh, thanks. I personally have a question. With some of the people in our community on Belviq, and Belviq is being discontinued, where might our community look as an alternative once that medication comes off of the market?
Yeah, that's a good question. I don't have any magic answers there. I would say that that's something they probably want to discuss with their each individual with their provider and see what would be the next best option for them if they, have not tried something like fenfluramine. Maybe that's what they look at. So is there another medication that has a similar mechanism? But I think that's going to be an individual discussion with each provider.
This on? Oh, it is. Okay. Hi. So over and over, like yesterday and today, we keep seeing that with Dravet syndrome, there's normally normal MRI when they do it for the first time. Our son had his first seizure at 3 months old and has always had an abnormal MRI, like low, I think it was low white matter, and his ventricles were enlarged. Is that atypical for Dravet?
Yeah, so that would be atypical for Dravet. I think that if you see a sort of a causal reason for for seizures on an MRI, that's a red flag. It doesn't absolutely rule it out, and so I think that's where we as providers need to sort of weigh the other presentation, the genetic studies, and say, is this just an atypical feature of somebody who has Dravet syndrome, or is this not Dravet syndrome? And so it sounds like your provider has weighed those, and so it would be a bit of a red flag. It doesn't 100% exclude the diagnosis. Yep.
Over here.
Hi there. Good morning. It was mentioned yesterday that immunizations could be a possible trigger, and our daughter presented with her first seizure about 3 days after her first round of immunizations. So wondering if you could speak to like an immunization schedule, best practices, and any things to watch out for in that sense.
All right, well, that could be a lecture on its own, but it is actually, thank you for raising that. That is a very common thing that we see in persons and children with Dravet syndrome. A not insignificant minority actually will have their first seizure in relation to vaccination. We do not think that the vaccine is causing it. The vaccine is simply usually associated with a rise in inflammatory mediators in the bloodstream, usually with an elevation in temperature, and then in somebody who is genetically predisposed, like somebody with Dravet syndrome, a seizure happens. If you did not do vaccinations at that time, and then your child got a bad cold, 2 months down the road, they probably would have had a seizure with that, right? So it's just kind of coming, it's allowing that to present more clearly a little bit early on, but it is not causing. I think vaccinations are really, really important for most persons with Dravet syndrome. And I know there's a lot of hesitancy and angst, and I get that as families, you vaccinated your child, you did what you were supposed to do, and then suddenly your child has this big, long seizure and has now a very worrisome diagnosis. But I think when we look at vaccinations, they're given for a clear reason, and we are now seeing, cases, for example, whooping cough in Minnesota. There's been now an increased number of kids with whooping cough, which is very, very problematic and certainly can be very stressful. And if you have Dravet syndrome, could be a potential trigger for more seizures. We also know that there's, measles is out there again because of less kids actually being vaccinated. So I feel very strongly kids should be vaccinated. But I think there's a way we can do that cautiously. And again, it's a discussion with your provider. What I often will do is I will make sure that the kid is getting an antipyretic agent like Tylenol or something like that around the time of the vaccine when we're expecting those temperature elevations to happen to try and reduce the risk of seizures. And then also sometimes, rather than give them 3 vaccines at a time, maybe you give them 1 and then you bring them back in a month and you give them a second. So they're still getting their vaccinations, but you're not kind of ganging up on them all at once. And then being sure that you also have a clear plan for rescue. And so that's a discussion, I think, individually to have with your provider. Oh, sorry.
Our table again. Thanks for coming out to speak with us. I had a question about, it's 2-part. So first part, do you know if there's any studies right now tying in AI in the course of treatment with Dravet or like drug interactions?
Sorry, the question was AI?
Yeah, if there's any studies with using AI to tie in like drug interactions or course of treatment with Dravet?
Not that I'm aware of. I think that we as physicians know which drugs can interact with each other, so it's really important for us to select medications, and if we're going to combine medications with drug interactions, to take into account those. But I don't know of any AI programs or features that help us with that.
All right, thanks. And then the other one, sorry, I didn't sleep very much last night, so I feel like my brain is mashed potatoes. So the other part was missense, nonsense. Genes in their presentation and how, if there's any studies with certain medications based on your presentation.
Not that I know of, but I think Dr. Helbig is going to be talking to us about genetics, and so that would maybe be a good question to save for him.
Noted. Thank you.
All right, well, thank you. One more question, and maybe that will be the last time. I'm going to be around today, so if other people have questions, I'm happy to answer those, but we'll take one more.
I can make this real quick.
Sure.
Help with potential appetite suppression. I'm a parent and a doctor. So Remeron, other options that you've used, since a lot of these cause appetite suppression.
Yeah, so a lot of the medications, as you're right, they can cause appetite suppression. I think it's working again with your provider to maximize seizure control but minimize side effects. I don't use a lot of medications to improve appetite, but what I often will do is work with our dietitian, see is there any particular supplements, is there any way we can sneak extra calories in? And so that's typically what I do for that. All right, thank you very much.
I was just going to add one quick comment to what we were discussing about the serotonin modulating drugs and failure and the likelihood of failure of a second one. I don't have published data, but I know personally at least like 15 families that have failed one and seen incredible success on another. So I think it's an interesting question to sort of watch as we see more of these drugs come out. It might not be as clear cut as fail one, none of them are successful. So I just wanted to mention it because it's been discussed a lot.